Hi, I'm Dr. Kathryn Dow, and this is QD Clinic. I'm going to present a case that's really important, and it's something of a case that you've probably seen in your clinic. So this is a 64-year-old female. She was a former smoker. She has diabetes, hypertension, hyperlipidemia, and also seropositive rheumatoid arthritis. So she comes in for evaluation. She's been taking methotrexate, 20 milligrams a week, hydroxychloroquine, and prednisone, 5 milligrams a day. On her exam, she has 3 tender, 3 swollen joints. Well, what would be your next step in controlling her rheumatoid arthritis? And how would you mitigate her cardiovascular risk? So this is about cardiovascular risk in patients with rheumatoid arthritis. And so in order to understand the cardiovascular risk associated with rheumatoid arthritis, we have to understand the risk associated with the inflammatory disease, as well as the risk associated with the medications we use to treat the inflammatory disease. Now, we all know the traditional risk factors for rheumatoid arthritis. That's obesity, hyperlipidemia, diabetes, hypertension, and tobacco use. But rheumatoid arthritis itself is an independent risk factor for cardiovascular disease. We know that RA is a pro-inflammatory state. It's associated with accelerated atherosclerosis, endothelial cell dysfunction, and microvascular disease. Not only that, the increase in cytokines associated in rheumatoid arthritis has been found to increase coronary calcifications. There's also been more research pointing to intravascular nets. So these are neutrophil extracellular traps that's been found in the vasculature of RA patients. And they're thinking that these nets may be contributing to the pro-inflammatory, pro-thrombotic, and pro-coagulant environment. And just having citrullination itself can be associated with cardiovascular disease, even in patients who do not have rheumatoid arthritis. In addition, about 40% of RA deaths are due to cardiovascular disease. And when patients have active inflammatory disease, so even a 1 unit increase in their DAS28, that increases cardiovascular risk by 33%. And we know that patients who are in remission, they have a 50% chance less of having a cardiovascular event. So it makes sense to control the disease to reduce cardiovascular mortality. But what about our treatments? We use a lot of NSAIDs, steroids, our synthetic DMARDs, as well as biologics. How do they impact cardiovascular disease? Now, there's been a massive number of cardiovascular outcome studies, particularly with NSAIDs, right? And this was partly because rofecoxib and valdecoxib was removed from the market a while ago. So they wanted to know, are NSAIDs safe? In a meta-analysis from 2011, they compared the different kinds of NSAIDs out there, like ibuprofen, naproxen, diclofenac, as well as a few others. And the authors found that the highest risk for strokes, cardiovascular death, and death from any cardiac causes is actually related to diclofenac. But what about the other NSAIDs, particularly celecoxib? It's the only COX-2 inhibitor on the market. So in 2016, the PRECISION study was conducted. Now, this is a randomized prospective trial, and it compared pretty good doses of NSAIDs to each other. So they took patients and gave them celecoxib 100 to 200 milligrams BID, or naproxen 375 milligrams to 500 milligrams BID, or ibuprofen 600 to 800 milligrams TID. And they gave them to patients with arthritis and who have higher cardiovascular risks. They treated them for 2 years and followed them for 3 years. And what they found was that the rate of cardiovascular events were actually very similar among the 3 NSAIDs. Celecoxib did not increase the risk for cardiovascular events more than ibuprofen or naproxen. How about steroids? Now, we know that steroids are bad for a number of reasons. It can cause patients to gain weight, increase the risk for diabetes. Well, steroids also can increase cardiovascular disease. The sad news, a third of our rheumatoid arthritis patients are on long-term steroids. There's a VA retrospective cohort study that found that even just giving a patient 30 days of glucocorticoids, it's associated with a higher odds of MACE in the next 6 months. And that's independent of any other cardiovascular risk factor. There was also another study that found that prednisone doses of more than 7.5 milligrams a day is associated with the risk of an acute MI by about 25%. So what about our DMARDs then? So NSAIDs, You can use them. Steroids, bad. But what about our DMARDs? With regards to the conventional synthetic DMARDs, pretty much all of them, like methotrexate, hydroxychloroquine, sulfasalazine, leflutamide, have been shown to reduce the risk for MIs, strokes, as well as congestive heart failure. Hydroxychloroquine had an added benefit. It's been shown to improve lipid profiles and decrease incident diabetes. More recently, there's been a prospective randomized controlled trial looking at triple DMARD therapy and comparing it to TNF inhibitors. And what the study did was that they measured arterial inflammation in the carotids by PET-CT. And they found that triple DMARD therapy performed about the same as a TNF inhibitor. Those patients who received triple DMARD therapy have the same kind of arterial inflammation reduction as those who are on TNF inhibitors. We know that TNF inhibitors are great. They've been shown to reduce cardiovascular disease. But is one biologic better than another? What about another mechanism of action? In a meta-analysis, they compared all these biologics and they found that pretty much all of them reduce cardiovascular risk. Now, I really think it's because the disease is better controlled. So that's the reason why the risk for MIs, strokes, heart failure have been reduced. Now, it's interesting to note in one of the studies that tocilizumab may outperform TNF inhibitors. What about the JAK inhibitors? Now, the FDA had issued warnings about JAK inhibitors increasing risk for strokes, thrombosis, and MIs. Well, this was based on the oral surveillance study. In one of the Tuesday night rheumatology, Dr. Janet Pope discussed the oral surveillance study. And essentially, this is a prospective randomized controlled trial. It's open label. And what they did was they compared tofacitinib to a TNF inhibitor. The study population was enriched for high-risk patients. So these are patients who are diabetics, they're smokers, they might have had previous heart attacks. And the way the study authors defined non-inferiority of tofacitinib is if the hazard ratio's upper limit of the confidence interval is less than 1.8. So they enrolled over 4,300 patients. They followed them for 4 years. And unfortunately, tofacitinib did not meet its endpoint of having the upper limit of confidence interval less than 1.8 in the combined 5 milligram and 10 milligram dose. Well, the confidence interval crossed 1. The upper limit of the confidence interval was 1.94. So that's higher than 1.8. But when you took out, just looking at the 5 milligrams BID dosing, the confidence interval, the upper limit of the confidence interval was only 1.74. Needless to say, the FDA noted that healthcare professionals should consider the risk and benefits for an individual patient prior to initiating and continuing therapy with these drugs, especially in those who have cardiovascular risk factors. So essentially, the questions have been raised. Is it that JAK inhibitors do not protect patients from cardiovascular disease as much as TNF inhibitors? Or do JAK inhibitors itself carry the added risk of cardiovascular disease? And perhaps do DMARD therapy, other background DMARDs matter when you prescribe a JAK inhibitor, like perhaps a JAK inhibitor in triple therapy with hydroxychloroquine and methotrexate might have the same protection. We don't know. And would you necessarily forego JAK inhibitors in patients with cardiovascular risk? So in my opinion, controlling disease activity, reducing steroid use, and controlling comorbidities are probably the most important factors in reducing cardiovascular risk. Choice of therapy depends on what will control the disease, the patient's preference, and insurance coverage. So back to the patient that I presented. What we did was we added sulfasalazine to her regimen. We were able to taper off her steroids, and she's been in remission. Thank you for watching. This is Dr. Kathryn Dow. Follow me on Twitter at KDow2011.